introduce our speaker this morning. Dr. Vincent Lafronza is someone that I hope all of you get a chance to interact with either today or in the future, because he's someone who has a pretty remarkable perspective on public health and healthcare leadership. Dr. Lafronza is the president and CEO of the National Network of Public Health Institutes, which is a nationwide membership organization with over 3 dozen organizations working on public health innovation, education, program implementation. And to give you a sense of the magnitude from the website, the budget of those membership organizations is just over $1.5 billion a year. So this is a pretty significant organization. The Tennessee Institute of Public Health, which we house here, is proud to be a part of NNPHI, though we're not as large as some of the other organizations. Prior to his position as president of NNPHI, Dr. Lafronza started 2 nonprofit organizations. He spent 10 years at the National Association of City and County Health Officials. He previously worked at the CDC. He's been in academia, the private sector, nonprofit sector, and really has expertise in environmental remediation issues, gerontology, the social determinants of health. The reason I said in the beginning that all of you should get to know him is anyone who's been successful at leading a variety of different organizations clearly has concepts and perspectives that we all need to understand. So please join me in welcoming Dr. Vincent Lafronza.
Thanks for that kind introduction. And this is my first order of business is probably to learn to use this right. I'm really glad to be with you all. This is the first time on your campus for me, and it's beautiful. I live in Virginia. I have a privileged job to work with institutes all around the country, so I get to see most of the country, and I will say this is just a beautiful part of Tennessee, beautiful area. Let's see if I do this right. So I would love this to be interactive, and maybe if you have more coffee, you'll. So we all go to doctors and we get hopefully annual physicals, right? And so what does your physician want to do? They want to sort of establish some baseline data on you, and they want to see how your health is progressing over time. What I love about public health is, we've got all kinds of baseline data on how we're doing as a society, right? And it's the same thing, we just do it in a real big population level. We know that life expectancy is one of the most important indicators that we have in terms of, how is the society doing? And I know you also have a great resource in Dr. Wyckoff, so I would imagine a lot of the data that you should share with us in the learning exchange, I would imagine you've shared here. So I'm not going to focus so much on the region, I'm just going to cover some basic pieces. This is 2014 data. You see we are starting to change the gap, reduce the gap, but we've got lots more work to do in this country. But when we look at, just look at Japan. I mean, what they're doing now. Obviously, a little bit more homogeneous population, but we're obviously, almost 10 years, just depending on which country you compare. We've got a lot of work to do on changing this, because we actually have more resources than many countries around the world. And I know you're all in school studying, ways to change the population. Also, we were just talking about falls prevention. This is a big public health crisis that's hitting us now, and I think the whole healthy aging movement really does need to take off. Thank you, that's better. Years ago when I was at NACHO, which is an organization that all your county and city health officials join all around the country, we tried really hard to get a healthy aging agenda. And it's interesting, and for whatever reason at that time, our Congress was just not interested in funding any of it. But we know from just what we spend at that side of the lifespan, we can do much better, not only in increasing your quality of life, just from basic public health interventions to reducing medical costs, right? And then we do have this sort of approach that we take in the country. Anyone want to comment? Why do we measure things by state? thoughts on that?
Regulations on different health aspects differ from state to state.
That they do? Any other thoughts on that? There's not a wrong answer.
That's where the data is. I mean, you've got this bulk of data being collected by state health departments.
We've got the data there by the state health department.
Different cultures vary state to state.
Different cultures. Please.
Income's different.
Incomes do differ, not only by state, but county and even town. What happened with the US is interesting because states have what we call health powers. And so this was written into our Constitution. So essentially, our whole data infrastructure around population health has been based on that. I would think, though, that in some ways it's holding us back from interventions that we could be making in our populations. And so what I love about the schools of public health, a lot of the work you're doing with your faculty here and also institutes, is that we could really change, we could keep that going. We're not going to change our Constitution around it, but I think we could do a lot more locally. And building those data systems to, really predict ahead of time before, that's another power of public health, right? You're predicting ahead of time before things are gonna happen. In Italian, the word for prevention, really, if you boil it down in Latin, it means before it happens, to pre-see something. So it's, before it comes. So if you look at different languages, they have different concepts about what public health is. And I know in your classes, you probably have seen some of these charts as well. When you look around the world, where are we, where do you see the United States? We're right around here. So in some ways we've improved. And again, the gaps are sort of improving, but we do have more work to do. And I'll leave these slides with Jenny so you can have them. Sudden infant death syndrome, and unexplained death syndrome, we're getting a little bit better, but again, these are major public health challenges in the country. And as we see the funding decreasing in a lot of counties and cities, we're going to see these numbers change. And so we really have to push our elected officials to say this is worth investing in. And by the way, for those of you, I hope you have really long careers in this, you are the future of public health, and it's not, to me, my own personal view on it, it's not a left or right issue, it's for everyone. And we've got to somehow in this country, we've gotten a little too, I live in the Northern Virginia area, do a lot of work on the Hill, educating elected folks. This is not a party issue. This is, no one wants to be sick, no one wants to have cancer, no one wants to lose a baby from an unexplained death. So we've got to get back to sort of a decent conversation, and I don't know, I think you all can do that. Your generation can definitely do that. More on infant mortality. Again, this is not necessarily going to be the case in every community, right? So when we look at the whole population, though, 6.2 per 1,000 live births, we can do much better. That number did go down, though. We were up to around 8. So we are dropping it. I just got back from APHA in Atlanta. That's the American Public Health Association. Georgia has done a lot of work in this state. I lived in Georgia for 8 years, and they've dropped the rates close to, I think they're down to just above 6 now. And they were, one of the worst states. So good public health interventions can work. And then we know the whole equity issues. These are preventable deaths, and there's nothing in terms of just most of this is not genetic. So we know it's within our reach to design programs that actually work. And these are the things you're studying in school. Some of you are doing practicum, and we'll talk a little bit about the institutes around the country where you can maybe get some more experience when you leave here. Again, just pregnancy-related mortality. A lot of research going on about this. Some of it has to do with, gestational diabetes. There's lots of different causes. Most of them, again, are non-genetic. They are preventable. And these numbers are definitely not going in the right direction. Anyone studying this in your classes? Obesity issue. A lot of it's the way we live in America, right? It's the way we design our communities. It's our it's not that we're not smart about it in the sense that we don't know why it's happening. But again, these are mostly non-genetic factors. What we eat, what I decide in the morning to do. But I also know my zip code is going to be a bigger predictor on obesity than other things too. So why is that? It's because my environment also shapes how I think about things and where I decide to, what kind of food I eat, where I decide to hang out, and what I eat at home. I also think in the areas where we have more traffic and longer work days, the nutritional intake is changing dramatically. We're starting to see that in Europe because they've always been way ahead of us. But as Europe has been more into the global economy now, I know even some of my own relatives that live in different countries in Europe, they're crunched now. They don't have the same time to prepare those home meals every night, and you're starting to see the younger generation, the obesity going up. So it does show you that you can make those changes, with good public health programs. But we have to also think about the multi-sector environment that we work in for our work life. And more businesses now are letting people telecommute to reduce the stress on them, and that's a whole interesting movement in America. And again, we go back to the state data that we have. I'm sure your region in here, you certainly know that those data points are going to be very different based on which counties you want to measure. We do know, though, that in some states they're actually starting to at least stop the growth of obesity. I know there's been a lot going on in the schools. We have a program with the CDC, the Centers for Disease Control, where we actually provide technical assistance to the educators in your states, working with the health departments to design better education programs and physical activity. A lot of states, though, they're so worried about the test scores that they're removing physical education from the requirements. Very bad public health measures, so we've got some education to do with those elected folks. Elected people don't want to hurt anybody, but what they want is to focus on the issues that they either ran about or care about, and oftentimes it's test scores. How well are you doing? And we know there's a lot of research that kids that are healthy are going to do better in school anyway. It's really a lot of public health is sort of common sense, but it's very hard to get it into the political cycle. And then we can talk about again, big differences in groups. There's also a growing Hispanic community in America, and the longer people stay here, the more they sort of adapt to the American culture. Then you see obesity rising and other problems. So we study that over time. So it tells you that in their home country, they may have had, in some cases, better health. But some of it's economically driven because you're also working longer hours. There's a whole living wage movement around the country, which is a tough one to win. But if I have to work 3 jobs just to pay my family's expenses, it's going to be much harder for me to achieve the kind of health status that I may have had when I came here. And that's also happening for people in lower resource areas where the jobs are leaving. I'm glad to see this campus. This campus is probably a very good economic generator of jobs for the region. It's nice to see that. Cost, of course, we spend a lot of money on this. So I know that elected folks are worried about our budgets. So the more you can do in your states, wherever even after you leave the school, wherever you go, the more you can educate elected folks about, these costs. I think it can be really beneficial. And I was glad to hear, Randy, that there's a good support for public health in this area by your elected folks. I think it's important. With our younger generation, we see increases in obesity at younger ages. And I know when I was in school, I mean, we really lived different lives. And some of it's our technology dependence, some of it's our level of activity, and how much time people are spending, longer work days, longer study days in high school. But again, public health interventions can work. And why you have to have the data, you need the data to track over time sort of what those interventions are looking like. And there's a big movement now for evidence-based practice. So, and this is what universities can help us with more. What's actually working? Can we see the studies? And then we can reduce the expenditures. And also, we need to start tying this to the cost of medical care. And again, I'd say it's not a red or blue issue. No 14-year-old wants to have this condition, and certainly no parent wants their 16-year-old to have a knee replacement. I mean, it's just, we can do much better with a little bit more investment and support for public health. This is maybe going to happen soon. I am more optimistic than this, but it's very possible. If we keep going on the trajectory that we're going in America, we may have lower life expectancy than previous generations. I'm a little more optimistic. We're starting to see more support for public health. And so I think you're studying the right field. And I just got back from the American Public Health Association in Atlanta. There's lots and lots of students, so there's obviously jobs out there for public health. So I hope that we can turn this in the right direction. Poverty, we know, and I know that you've heard from Dr. Wyckoff in this region how poverty sort of influences and even can predict life expectancy, other types of public health challenges. I don't have the newest data. We're waiting on Census Bureau to come out with some new poverty data, but these numbers, we do better. We've changed right around the 2000 mark, and now I would imagine as we go up to 2015, 2016, you're going to see some of those rise. The economy right now has improved. The question is it improving for every community in the country? And some of this has to do with trade policy, right? People don't think about public health and jobs in the sense when they're making macro policy, but the more jobs that we have, good jobs in our communities, we know that will have a tremendous impact on health. We had the privilege last year of hosting the National Conference on Tobacco or Health that CDC runs. It was the largest convening in the history of that group. We had over 1,800 people from different countries come. It was the largest meeting that NMPHI ever had to do. And I was really pleased to see the progress that we are making globally on the smoking rates. Is this a tobacco-free campus?
Yes, indeed.
Awesome. Another good trend. We were just in Atlanta for the Public Health Association meeting. Atlanta is not one of the smoke-free, and I used to live in Atlanta. It's a very tough city to get, completely tobacco-free. And APHA has said, we're not going to go to the cities until these local governing bodies change the policies. We did get it changed in New Orleans, which was an amazing feat for public health. It probably took more than a decade to get that to happen. And there were lawsuits from the casinos. They're doing fine. So we know the data show that when you make those places smoke-free, people still come. So it's, again, the data can be so helpful. We're doing a little bit better on unintentional injuries. And you've seen, every day we see more and more news on sort of the gun-related deaths. This is, again, this should not be a political issue. There's ways to manage this in society. And what's interesting is, when we have more and more safety measures and more registration and background checks, we do see improvements. So again, we should depoliticize this and do the right thing. And there's been, some of this is, you know, more attention to the safety measures, so we are moving in the right direction. But I also think we've got to talk about mental health. So it's not just, you know, your issue, whether it's gun violence or mental health. How do we start to connect the dots on that and build programs that identify the problem earlier and intervene? And some of that I'm sure you're doing in this region. Insurance, the Affordable Care Act has been a very big political fight in this country. Everyone, no matter what country you live in, we need access to medical care, but we also know it's not the whole pie. What I love about, you know, what we're doing with part of the Affordable Care Act, and I hope we can keep it, and I don't care what it's called, it could be renamed, but we have the prevention fund, which is huge. And that prevention fund in legislation is growing each year, and those dollars are supposed to be going to state and local governments and federal governments and nonprofits to do the kinds of things that you're studying in your classes. And unfortunately, when you have a fund, it becomes a target, and a lot of elected officials are saying, well, let's take from that fund and we'll fund the child health care insurance bill, which expired, by the way, which, you know, we shouldn't be doing. We need to make sure that our kids are covered, that's the National CHIP program. And so they want to take the money from, you know, one good public health measure and put it in another. It would be a huge loss. Some of your grants that go to this school, I would imagine, come from the prevention fund. So we do have to preserve that. And of course, we see, you know, vaccine preventable outbreaks. There seems to be a movement in certain parts of our country where people are saying, you know, we don't want these vaccines anymore. Again, we know from good public health data all around the world that your risks are certainly much higher. I mean, there's always going to be some side effect from some medications, but your risks are much higher by not vaccinating. This over here and also out west, you know, this is another public policy issue that has to be seriously looked at. And again, I know that parents that make decisions for their children, they certainly don't want to hurt their children, but some of it's just not being aware of the data. HPV vaccine is on another really good public health intervention. Public policy comes in to the argument here. Does Medicaid, do we keep these things in our policies, or do we say we're not going to let Medicaid pay for it? And then what happens? You see a drop in the usage. Any problems here with that on campus? We are doing better in some communities, for sure, on alcohol consumption, but again, it's mostly not a genetic behavior, right? We can change these things. That was a pretty startling statistic to me. I personally didn't realize. I don't do a lot of work on this area in public health, but I didn't realize that it was just so high. And again, very, very preventable. Suicide is also another big worry in the United States. And we're not really sure. I don't know that there's a lot of good evidence to know why this has happened. Why the rates are going up. Emerging infections, we mostly work in the United States, but there's a few institutes that do work overseas. And part of this is related to antibiotic resistance. Part of it's related to other things that we're not really sure. It could be some climate change issues as well. But our CDC in Atlanta is very, very concerned about the changes here. And again, you've seen it with Ebola and other problems. And I think there's some new disease that's out of Africa now that they're one of the African countries that they're tracking. this is a problem in especially large populations in India and other places where they're overusing interventions, drug interventions that we probably could do. We have a program with CDC where Public Health Institute out of California, which we'll talk about in a minute, they're trying to train physicians in India about prescription behaviors and things, and it's really hard to do from our standpoint in the United States to have CDC doing that in other countries, but I give them a lot of credit for doing it because that can have a huge impact globally. Mental illness, again, is on the rise. Some of this could be the way we collect data around this. We do have a better data infrastructure. NMPHI has a new problem, a new study with CDC to help design a better surveillance system for children, which I think is really good, because we don't have a lot of good surveillance systems around mental health with younger folks. This won't surprise anyone. The latest data now, this trend unfortunately is about up here. We're not going in the right direction. I would imagine you've got some work going on in this university on heroin and opioid addictions. And this is obviously related to mental health, right? So our traditional training in public health, today it's great, you guys are getting exposed to the right things. Our traditional training in public health wasn't really about mental health, it was much more standard public health measures. And the infrastructure has a major role here, because when you see these funding gaps, right, so we have a limited federal budget, you have limited state and local budgets. As we have to put more money into our infrastructure, which has an impact on health, we're gonna see some real pressure on state and local governments. Mentioned this before, this should not be, by the way. Our zip code should never be the predictor of life expectancy. And that just shows you that a lot of population health can be manipulated in a much more positive way. We are probably doing better on this if you look over time, but still look at better on medical errors. These are decreasing, but the heart disease piece here is really worrisome. So what do we try to do about all of these things, right? So the National Network of Public Health Institutes has been designed to do three major things. We want to build institutes around the country, one of which is yours here, and we'll talk a little bit more about that. We want to promote multi-sector initiatives that actually can create health, not just react to disease. And we want measurable improvements in systems and outcomes. And we do that through the structure of our multi-sector partnerships. And the Institute here is all about what you can do with different types of partnerships across the state and even in the region. So this was designed to connect the institutes around the country. And so we have right now, and the number changes from time to time, right now we have 41 public health institutes around the country, all different sizes, and they're doing different work in public health, but there's some commonalities among them, which we'll talk about in a minute. We have, most of our staff is in New Orleans, Louisiana. Believe it or not, NMPHI was founded out of New Orleans. And so when I took this position, I was actually on the board and I was running one of the institutes we started in the DC, Virginia, and Maryland region. And I just decided that if we were gonna really be connected to what's going on the Hill and also the other national organizations, I wanted to be in the DC area. So we kept our New Orleans staff, and we have staff in Atlanta now, and we have staff in DC. So for those of you who are gonna be looking for jobs soon, we can help you connect to jobs all across the network. the network is often hiring. We also have recently brought on 10 regional public health training centers through HRSA work. And these are all at accredited schools of public health, and NMPHI serves as the national coordinating center for these 10 regional public health training centers. You all have access to everything that the training centers develop, and it is all free and open source. So I encourage you to go on our website, get to know the training centers, even if there's not one, even if there's a training center out in Seattle, University of Washington, you can take classes online that they actually develop, and so can your partners. Randy mentioned before, in terms of if you put all of the institutes, all the 41 together, not the training centers, but the 41, you get about $1.2 to $1.5 billion worth of programmatic activity. Now we're tracking this over time to see what the health of the network is in terms of our public investments. Most of this obviously is grants and service contracts. And we've got more than 20 institutes with about over 2.5 million in revenue. And we're not so much interested in just the revenue, but money as a proxy for support and for the use of an institute. And we're really worried about our training centers. The House bill has zeroed them out, and the Senate bill has put them back, and they haven't done the conference committee yet, so we don't know what's going to happen. But there's some folks on Capitol Hill who say we don't want to invest in public health training because that's not a federal role. The states should do it on their own. That's the House side. The Senate side is saying that's probably not an efficient way, and it's going to push the state budgets up because you got to do the training. Most of the people that go into the state and local health departments do not have the background that you all have. So most of our workforce is not trained in public health in their undergrad or graduate curriculum. That is of course changing based on the number of you in this room, which is great. So we try to give out about half of our annual budget. So our annual budget is much smaller than the composite of all those institutes. But in the last 4 fiscal years, we've awarded over $10 million in projects that we do with the institutes, and you have some of that award. We'd love that to increase. So we love to be a re-granting agency to build capacity of institutes. It's getting harder because a lot of our funders, their budgets are smaller, and every time Congress says, well, we'll just do level funding on this, it's really a cut because there's inflation. So it is getting harder, but that's part of my job, is to see that how can we help the institutes around the country. So we have a lot of financial strategies underway. The whole diversification of funding entities is a very important piece of our strategy right now. We're trying to get money from SAMHSA, the Substance Abuse and Mental Health Services Administration, because we know a lot of the work that they are doing in communities relates to good public health. It's hard for us to get in there because we're so associated with CDC that they see us as that those are the traditional public health folks. So we're going to change that. It's going to take a heavy lift. And then we've been reading some LaPiana's book on real-time strategic planning. So we don't have the luxury of doing these 3- and 4-year plans anymore, but it's got to be much more rapid. How many of you in this room have written any grants with your faculty? All right, this is one of the things I say to students all over around the country. Learn how to write grants. If you can, pair up with a faculty member. I'm sure Jenny would love to help. It's really, really important skill. And I had to learn it the hard way. Just, get your feet on the ground to keep your job going. And at NACHO, when I worked at NACHO with the county and city health directors, we wrote a lot of grants. And you do get better at it, but they're very, very competitive. We also do a review of public documents. So 990 basically, for all nonprofits in the United States, they have to file with the IRS a public document that states what their revenues are. It's a little bit harder when there's institutes embedded in a university because your resources are embedded in the university's financials, so we don't always know. But we do study this over time to see how it's changing and how we can be more influential in getting more money to institutes. So we did see the last study we did was 2014 to 2015. We did see a little bit of a decrease in the institute's budget overall. Now the last one we tried to do, we couldn't do it because the 990s are delayed. So some of the institutes may have asked for extensions or filed later, but we have a new study going on. I'm hoping that we can see it about, going back up again. So just to give you an example, in 2016, for nonprofits, for our nonprofit, we wrote 94 grants last year. That's a lot of grant writing, but you gotta do it. And we had an 80% success rate, which is pretty remarkable. This year, we're studying it again, it's not gonna be 80%. And why do we measure this? Because we wanna see the field competition. The competition is increasing for grants, for sure. So I would guess our success rate is probably gonna be around 60 this year, but as long as it's over 50, I'm still happy. What do we see in Congress? Health and Human Services, overarching priorities. We don't have a secretary right now, but what Secretary Price, when Price was in, he definitely wanted to replace the Affordable Care Act with a new bill. Congress has not been able to do that, and there's for good reason. It's a very difficult bill, complicated to do that for all 50 states. Emergency preparedness, the hurricanes just are reminders that we have to continue to invest in this work. The childhood obesity work is still high on the list, as is diabetes. And you all have seen this in your region, increased investment in the opioid epidemic. I hope that we can get to a real prevention agenda on opioids. I think we have a long way to go. We're still in the intervention stage where it's pretty late in the process, even though you do want to get in the naloxone and you want to eliminate those deaths, but that's not necessarily going upstream enough. So we've got to, I hope we can talk about that a little bit during my visit today. And then we do see, there's an expectation among Congress to have smaller governments and more efficiencies, which provides an opportunity for institutes. Because what we can do is support the work of local governments, and we do that every day. And so if you want to get a job in public health at an institute, there are definitely opportunities, and that relieves your local government of having another position. This is sort of what I think is happening in America right now, and I hope we can turn this around. When I think of public health, I think it's really about human development. And it's not just the health side of it. Health is the outcome of these investments. But we are seeing a shrinkage in that interest from our public officials in terms of investments. And I think we are on a dangerous trajectory for that. We see some increases obviously in poverty. I know where most of our cities, you may not have it in the rural areas, but most of our cities are seeing very, very significant rises in homelessness. And then this whole sort of disinvestment in public education, which is not just happening in America. There's this bifurcation of folks going to more and more private schools at younger ages, and there's some folks assaulting science that we don't climate. I don't care if you call it climate change. I mean, it's happening. All you have to do is look at data all around the world. And again, it doesn't have to be a Republican or Democratic issue. It's happening to people living in communities, to all of us. I talked a little bit about aging, really, really important. I would venture to guess if we don't make some changes in our public policy, we're going to have lots and lots of older folks unable to care for themselves without enough money. And you look at the average savings in 401k and other retirement plans, it's insufficient for living longer. And if we do live to be, let the average male maybe say 80, 86, 87, if I retire at 62 or 65 because of a health condition, because I thought I was going to continue to work, I could easily run out of money. And we're seeing greater inequalities. We are seeing overall life expectancy increases, but in certain areas, like where I live, in the Northern Virginia, DC area, you could go 3 to 4 metro stops and see a 10-year life expectancy differential. And that is not a genetic condition. That is something that we have done with our sort of policies around pay and education, access to education, all of those things. In a general sense, I think we have a reprioritization of our societal goals happening right now. Maybe lots of countries go through this. You're starting to see it in Spain right now with the whole issue of splitting the country. I think it's happening here. I think we have to get back to some basics about what do we want to invest in, what kind of society do we want. And these are just my personal opinions. These are not sort of necessarily agreed upon goals of NMPHI. And there's a greater pressure on state and local governments, and I don't see this going away anytime soon unless the economy really does pick up, if we get to a 6%. Annual growth rate, but most economists are saying it's probably not going to happen. So our members all across the country are trying real hard to build public health capacity. More and more we're seeing the larger institutes are on the coast. So California has a very large institute, probably about $180 million budget every year. They work all around the world. They're about 53 years old, I want to say. New York City has a very large public health institute, probably 50 some odd years old. And they do a lot of work with their, the population in New York is talking millions of people. So they do a lot of work with their city health department. But the coasts seem to have more of the, much more of the resources. There's a lot of institutes like yours that are small, and we'll talk about that more today during the site visit, but it's not necessarily a bad thing to be small, but as long as you're growing and as long as you have a growth plan. What you will notice as you start looking for jobs is not every institute has an institute in its name, and you may not know that they're part of NMPHI, but you can go on our network, on our website, nmphi.org, and you can find all the institutes around the country. And it has their contact information, it has their website, so I encourage you as you start looking for jobs to, peruse their openings. Also, Emory University in Atlanta has probably one of the best job sites in the country. And it's not just for Emory, it's for all public health jobs. It's the Rollins School of Public Health. Why public health institutes? What do they do? Some of them are fiscal and administrative managers of funds. So for example, in New York City, the city health department has to do all the emergency preparedness contracts. The local government the city government doesn't want to do that, so they give all that money to the institute and they say, here, you guys run these contracts. They do retain some intellectual control over the work, but that's a good example of a service that institutes provide, and then they can make a little bit of money on those services. Population-based health program delivery, a lot of the work the institutes do, obviously, it's not about, direct medical care. Some institutes have some direct programs and mental health. Some institutes do some direct programming in education, but generally, like I know Philadelphia, they have a daycare center. Some of them are trying to raise revenue through other social supports, and then they get to work with those families in the daycare center on other public health issues too. But generally, it's more of the population-based approach. We've got some institutes that just do health policy. They don't necessarily do the program side, but so when you're taking your policy classes, they may work with your Tennessee state legislature on, should we expand Medicaid or not? So they might actually do all the policy analysis for the legislature. And that's just what they want to do. They don't necessarily want to do the programming side. A lot of training and technical assistance, research and evaluation services, health information services and surveillance work. So there's a lot of data experts around in the institute. And then more and more we see social marketing. How many of you are engaged in Twitter or I don't even know what the new social marketing is. What do you guys use?
Facebook, Snapchat.
Snapchat, that's a big one, yep. I was told Facebook's only for us old folks. So again, we're seeing a lot of innovative programs happening with social media. And then there's a lot of convening and partnering, having statewide meetings. I just returned from a different meeting in Georgia. Every year we run the state of the public health in Georgia. I really encourage every state to be doing that. We brought 300, it's our 6th annual meeting. I'm a graduate of UGA, so I help the College of Public Health with this every year. We have 300 plus folks come from around the state, every corner of Georgia, and talk about how's the state doing, what can we do better. We bring folks from the media, we bring folks from public health, we bring folks from universities, we bring folks from state and local government. A really important role. This is actually not run out of our institute there. It's run out of the College of Public Health, but we bring in the institutes. In fact, Dr. Wyckoff was a speaker there. They still talk about your presentation. That community has really grown, and now it's not just an annual conference. So again, these institutes are really important, have a very important role in sort of bringing folks together. There's a lot of good reason why we would want more institutes in the country, because it does reduce the reliance on more and more state and local governments, and I know that can be very expensive, especially when you look at the long-term pension investments that you have to make. So we're a much more economical approach. And I think more and more we're seeing this whole link between public health and healthcare reform. Institutes are really getting good in that space. More and more entrepreneurial approaches being developed in the institutes, which really all that means is instead of just relying on your grants, you've got to bring in other revenues. So you have the evaluation services are a good example. Any service you can bring in a nonprofit entity, you can make profit, we call it surplus. It just has to go back into your mission. So there's nothing wrong with making surplus. The old way we were trained is, don't make any surplus, you spend everything on your grants. But we're seeing that we're having to change our strategies in order to grow an institute. We'll talk about that later today too. And then the whole technology revolution and communications institutes are really, I think, stepping up to the plate. It's harder for local governments to do that, harder for them to invest in that. Case example. So how does this sort of play out in the real world of an actual benefit to the state? In California, they have created a public health trust, and the institute had a major role in that. So basically, it's like their own prevention fund. And then in Massachusetts, they have a prevention and wellness trust written into state legislature. The institute had a huge role in making that happen. And then they help give out the grants that come from that trust. So basically your state is saying, your state elected folks are saying, we're going to put this budget aside for real prevention work. And then we're going to let the institute help manage the grant making. So it's a really good example of how an institute can be effective. It would be hard for a state government to do that. Not impossible, but it would take a lot more policy change. We also have found that a lot of state governments say to us, well, we don't know that we want an institute here because they're going to take money away from our state governments. What we found is with institutes bringing more resources, it actually grows, and it's not the competitive side of it. Now, obviously, if we do remove the prevention fund and we shrink government, that's gonna create a lot of challenges for the network, because then it would be more competitive. In Illinois, they have done a really great job at changing the statewide physical education policy. something that I think they're very, very proud of. It is now, again, required in all schools, and they were able to turn that around. They did also pass a soda tax. I don't know if you've seen that in the news, which was great, and then it was repealed by the industry. The industry went after it, and they were very organized. And there were some really challenging public health policy issues around that soda tax, because some people said it ended up to be a tax on the poor, and so the political piece got tough. So sometimes you have a win and then you lose, but they're going to be back at that tax again, I'm sure. Georgia, I would encourage you to, for your institute here, I would encourage you to look at what Georgia does. Kansas and South Carolina do too. They have a legislative education program that the institute runs. Anyone that's a newly elected official, doesn't matter what your background is, doesn't matter what party you belong to, they provide a free program. I'm not sure exactly how each of these institutes gets the funding for it. Some of the state legislatures chip in money, but they actually have a program where they bring their elected folks through what is public policy about with public health. How do you make good public policy around public health? And it's not left or right. It's a factual program. And what they're finding is they get huge enrollments, and these folks are then prepared. Like a lot of them don't know. I'm newly elected official. I don't know what Medicaid policy means. I don't know what public health infrastructure is about. So they go through all of that. It's a very smart role for an institute. Ohio Institute of Public Health has a very interesting value dashboard. So they give to their state legislature. These are our investments in Ohio, and these are our return on investments. And so a lot of times the state legislature just thinks, oh, you're wasting money and prevention dollars, and we don't have the evidence. So they've designed a tool. I would encourage you to look at that. And it really does make a difference, because I think a lot of folks, when they have to vote for something, they're just not sure. And so the more data we can give them, it makes it much easier for them to make statewide policy. Michigan is a very large institute. They have a master contract with their state health department, and they run many programs in performance management for the public health departments in the state. So they do a lot of training, very effective model. And when you have a statewide contract with your health department, it's easy to get those dollars right through fast. So once you have a state contract, then they don't have to go out for rebid in public domain. We are also developing and refining our evaluation logic for emerging institutes. We want to know about the whole sort of context for the history of the institute. How does it engage with us? How can we be helpful in that engagement? What's the organizational stability? And do we have any evidence of impact? Because what our funders say to us is, if we're going to back you, you're going to have institutes behind you that we know can do the work, and we want to see what that evidence looks like. And I think we've got some changes to make to our model, but I think overall it's working pretty well. We get a lot of funders come to us again, so we get repeat business because they trust the network, and some of that's a trust factor. We know, obviously, there's the funding challenges that everyone is having in public health. You need to have some core funding for an institute, and then you need to have project funding. The core is becoming the tough nut to crack. So in other words, you have a solid budget that the school gives you and chips in. Some of the university-based institutes that actually don't have to pay rent, and they have other benefits that some of the nonprofits standalone don't have. But big challenge on the core. We have different types of members. I'm not going to go into all of this in the interest of time. But some institutes are small, like 10 member shops, and some of them have 1,500 staff. So it's real big variety. And then I have goals every year that I work through with our board strategy. You know, who are our partners? Like, we want to get into SAMHSA, we want to expand beyond CDC, and then how do we connect those goals with some of the national, state, and local trends happening? So we want to stay relevant as a network. I won't go through all of these. Some of the goals here are, you know, we do measure our network satisfaction, how happy are people when they work with us, what are the benefits that they're getting. We definitely want to explore new business with new sectors. We just submitted a grant to the Department of Justice. We were not successful. They encouraged us to apply again. It's all about the opioid epidemic training for the law enforcement community. We got a pretty good score on the grant, but it was highly competitive, and they only funded one national organization to do it. So we're going to continue to try to bring in those other resources, because that way we can get in, I think, earlier with the opioid epidemic. I mean, because the law enforcement community is really struggling, you know, with that. They're the ones that, you know, they're first encountered. Another goal that I have is, you know, how do we measure our success as a network? So we want those measurement pieces to be informing where we should put our resources. Healthy aging is growing. When we look at where members are building capacity, mental health, as I said, and telehealth is a real big issue. You probably have a lot of that going on in Tennessee and in the whole region. Another slice on public health practice. You know, you have your traditional public health prevention, your clinical prevention, and then the bucket of community-wide prevention. CDC is trying to put resources in this third bucket, and they're trying to figure out ways that we are connecting these three so that we're not just operating in silos. So there's a method across the different sectors, and you'll see a lot of, you know, talk at CDC around how do we connect the buckets. So when you're writing grants, we use clinical models in our grants. Competition, I've mentioned again about competing with partners. It's hard in the network sometimes because you feel like you want to support both your local, state government and your institute. So as the funds dry up, what's the competition approach? What we have found is that we're stronger together than we are apart, and so the relationships that you form with your other entities around your region are really, really important. I want to watch our time. I want to ask what thoughts you have, what questions you have about the network, or about our work in public health. So I'm not coughing.
One quick question. If you mentioned grant writing, are there other skills you're going to be looking for, you think, in 5 years or so for the workforce, things you'd encourage them to focus on?
Well, for sure, I think data, there's a big push on evidence-based practices. So people don't want to fund things that we don't know work. So you could write good grants, but you have to know your data sources. And I would imagine you're covering that in your curriculum. I think integration of mental health and behavioral health and public health is another really important area. I would also say multi-sector studies where we look at initiatives in other countries and in our own country where you're building health from the ground up. So how are you working with education? How are you working with employment? How are you working with those different sectors to actually make a public health intervention? And sometimes you won't even enter it from the public health side.